Good afternoon and welcome to Internal Medicine Grand Rounds. There is no commercial support for today's program. Any financial relationships of the planners and speakers with commercial interests have been mitigated. If you have a question for our presenter today, please hold until the Q&A segment. And if you're viewing online, you may post your question into the Q&A section and we'll read that aloud during the Q&A segment. A link to the evaluation will be shared at the end of the program. It is now my pleasure to introduce our guest speaker, Dr. Cindy Idowu. Dr. Idowu is an internal medicine resident at Northeast Georgia Medical Center. Born in Zambia, she immigrated to the United States in 1999 and was raised in St. Joseph, Michigan. Her educational journey began at Lake Michigan College, where she earned an Associate of Science degree, followed by a Bachelor of Arts in Anthropology from the University of Michigan. Prior to pursuing a career in medicine, Dr. Idowu gained extensive frontline healthcare experience as a nursing assistant, emergency department technician, and a certified emergency medical technician. These roles fostered a deep commitment to patient care and provided valuable insight into the healthcare needs of diverse patient populations. Dr. Idowu earned her Doctor of Medicine degree from St. George's University School of Medicine in 2023 and subsequently began her internal medicine residency training at the Northeast Georgia Medical Center. Upon completion of her residency, Dr. Idowu plans to remain in Georgia and pursue a career in hospital medicine, continuing her commitment to serving the community she now calls home. She is married and the proud parent of 2 children. Join me in welcoming Dr. Idowu.
So this afternoon, my topic is going to be GLP-1 receptor agonists, an update. A lot of us are prescribing these for our patients regularly as we learn more and more about the overall cardiovascular and other benefits associated. So I just wanted to teach our new interns and then reiterate, some of the benefits to the residents who've already been practicing. All right, without further ado, here's my disclosure statement. I have no financial or other relationships that could be perceived as influencing the content of this presentation, and any discussion of medications or other therapies will be based on available evidence and will identify off-label or investigational uses when applicable. The objectives of this presentation are to define what metabolic syndrome is, summarize the importance of the clinical outcomes of GLP-1 receptor agonists, especially as they pertain to the definition of metabolic syndrome, as well as outline current FDA-approved indications and emerging uses for GLP-1 agonists, receptor agonists. All right, so what is metabolic syndrome? So this is essentially a cluster of interrelated risk factors for cardiovascular disease as well as type 2 diabetes. The core components center around central abdominal obesity, which is something I'll mention later, an interesting thing that I read, atherogenic dyslipidemia, as well as elevated blood pressure and insulin resistance or dysglycemia. Also associated, metabolic syndrome is also associated with pro-inflammatory and prothrombotic states. So this was the interesting thing. I was reading one of the articles on GLP-1s and metabolic syndrome, and it talked about weight distribution, and it was interesting to me that not only do people with central adiposity have increased risk for cardiovascular disease, but those who have gluteofemoral or leg and thigh subcutaneous adipose tissue distribution have association with entrapment of free fatty acids, which essentially decreases the amount of ectopic free fatty acid uptake, like in the liver and the pancreas and the heart and places we don't want fat, decreases markers of insulin resistance, decreases inflammation, and cardiovascular risk. So the people distributed differently also have the benefit, not just are neutral, than those who have the central adiposity distribution. So that was interesting to me. So this is the harmonized diagnostic criteria for metabolic syndrome. In order to be diagnosed with this, you need 3 out of 5 of these listed here. So you can see weight circumference for men, 102 centimeters, and females, 88 centimeters. Hypertriglyceridemia or getting treatment for that. Hypertension or getting treatment for that. Decreased HDL, 40 for men, 50 for women, as well as a fasting blood glucose level greater than 100, or you're getting treated for type 2 diabetes. Now, the importance of the prognostic factors associated with metabolic syndrome are that roughly 1/4, which I think is a gross underestimation in my opinion, of North American adults have metabolic syndrome. I'm sure most of you, with just looking at your clinic panel of patients, feel like 3 out of at least 5 of those are met with a lot of the people on our panels. Also, metabolic syndrome is associated with a 2-fold increase in cardiovascular disease in 5 to 10 years, and a 5-fold increase in the development of type 2 diabetes. Also, diabetes, so if you have metabolic syndrome, you're at risk of getting diabetes, and then diabetes in turn is considered one of the most common causes of chronic kidney disease, and the presence of both of those, metabolic syndrome and chronic kidney disease, has an additive effect on cardiovascular risk, right? And so those are some of the reasons why metabolic syndrome is something huge to recognize and huge to focus on getting rid of. Metabolic syndrome, now sustained remission. I was reading another article that discussed about metabolic syndrome and how difficult it is to achieve sustained remission. And 3 high-quality trials with large and diverse participants all showed that you can achieve some, at least 22%, sustained remission for metabolic syndrome, but that was only if you were actively getting treatment for the metabolic syndrome, like lifestyle modifications and trying to lose weight and exercise and all of that, and healthy diet, right? However, you have to continue the intervention for the entirety. Here they studied about 24 months or longer. You had to continue the intervention for that duration in order to actually see the 22% reduction in metabolic syndrome. So then, enter the ELM study, which was a randomized clinical trial that wanted to see, hey, can we sustain remission for up to 24 months with a limited period of intervention? That was the main difference between this one. And ultimately, they gave these lifestyle changes between eating more vegetables, being more mindful about taking care of yourself, and then exercising a particular, whether it's brisk walking or cardiovascular exercise for a particular amount of times a week. Can we do that for 6 months and then see sustained remission at a 24-month period? And the results essentially showed that 28% of the people in the study, compared to the 22% in the prior 3 studies, did have sustained remission with intervention in a 6-month period, compared to the comparator group who just got not only the intervention, but just got the education and the mindfulness and sort of the tracking. However, this still noted that either utilizing medications, and specifically mentioned GLP-1 receptor agonists, would help make that sustained remission even more than 24 months if they were able to do not just lifestyle modifications, exercise, and diet, but also add a GLP-1 receptor agonist during the intervention period. Next, the importance of GLP-1 receptor agonist therapy for metabolic syndrome. So this is sort of what we've talked about already. GLP-1 receptor agonist simultaneously targets several metabolic syndrome-related components, right? We're losing weight, we're controlling blood glucose, we're controlling our blood pressure, which we know even losing weight can help with blood pressure. We're helping our hypertriglyceridemia, and all in all, in decreasing that adiposity, we're decreasing overall inflammation, which makes this drug class essentially ideal for the treatment of metabolic syndrome. As I was preparing for this presentation, I thought about, this is a little silly, but it's like going to the grocery store, not the grocery store, you're going to a retail store and you're trying to buy a dress and you find that dress that fits absolutely perfect, as if it was made for you, tailor-made for you, right? That's sort of how I was looking at the GLP-1 receptor agonist. I feel like metabolic syndrome went to TJ Maxx and found GLP-1s, which were tailor-made essentially for metabolic syndrome, in my opinion. This is, I would say, my baby for this presentation. I specifically asked open evidence, because I'm seeing all these articles and how they're covering all the aspects of metabolic syndrome, and I was like, can you just line it up for me real nicely in a table? And I think this is, if this is the only thing you take away from this presentation, this is what I want to get you guys to sort of see, okay? Especially interns just coming in, because now you're starting with these patients, and then by the end of your 3 years here, you can make some real big changes in patients' lives. And a lot of these studies I'm talking about, you'll see later on, actually the average amount of time that these studies were done for was about 3 years when trying to see cardiovascular risk reduction with GLP-1 therapy. So the most important part are these first two columns. You see, these are the harmonized criteria I was talking about for metabolic syndrome. We have the abdominal obesity, waist circumference as specified here, and GLP-1 receptor agonists do exactly that, reducing visceral fat and total body fat, right? Here, the triglycerides, when you have elevated triglycerides greater than 150 or you're getting treated for this, overall lowers triglycerides. We have the mechanisms here if you guys want to read on them. I don't want to, read every single word. But here the HDL cholesterol again, modest increase in HDL cholesterol with GLP-1 receptor agonists. Blood pressure, I'll see, there's another slide that sort of talks about how, this does too, the endothelial functions that benefits that you see with GLP-1s essentially can help us with our lower blood pressure. I think this is a lot of where that cardiovascular risk decreased non-fatal MI and non-fatal stroke come in here. And then fasting blood glucose, harmonized criteria. Here, this is where a lot of our GLP-1s are utilized and have the biggest impact. So I thought this was an awesome chart that it was able to compile for me. And here's, sort of where the evidence sits. We still have randomized controlled trials for a couple of these, but most of them very strong evidence related to GLP-1 effects and metabolic syndrome. Okay, so short snippet, because this is history and can be a little boring, so I tried to summarize it all. But this is where it all started, discovery and drug development. Glucagon-like peptide 1 and glucose-dependent insulinotropic peptide, GIP, are called incretins, right? Which are insulinotropic peptides cleaved from glucagon, or rather pro-glucagon. These are created, respectively, GLP-1 and GIP-1s are created in L cells of the distal intestine, small intestine, as well as the K cells in the proximal small intestines. And ultimately, a large part of their effect is on the pancreas. The pancreatic beta and alpha cells. And respectively, both of them were found to enhance the glucose-mediated insulin release, right? Glucose-mediated being the important aspect. All right, and then discovery and drug development continued. So now, GLP-1 receptor agonists are incretins, analogs, that are created from exendin-4, a peptide isolated from the Gila monster venom that was found to be structurally similar to the GLP-1s, but had a longer half-life. And on top of that, competed for GLP-1 at the receptor level. So the clinical trials established essentially the glucose-lowering effects of exendin-4, and in 2005, exenatide, which I didn't realize what they did there initially. I know exenatide, I know exendin-4, the name, but exenatide did become the first incretin analog approved for the treatment of type 2 diabetes. And there, thereafter, a lot of trials came up, sort of studying all of these incretins and how they can replicate, duplicate, or extend the life of the effects of these incretins or incretin analogs, as well as decreasing their metabolism by the DPP4. So some of the most popular approved medications include, and a lot of the ones that the studies are based on include liraglutide, semaglutide, dulaglutide, exenatide, as well as tirzepatide, which is the first GIP-GLP dual receptor agonist. Say all of these super fast without tying your tongue. So mechanism of action on a cellular level, again, I won't get, too detailed, but this is important to see essentially what we're doing when we're giving patients these medications, how they exert their benefits, as well as where some of the adverse effects are coming from. So here in the brain, increases satiety, does work in the hypothalamus, so that's where that comes from, which decreases appetite, reduces food intake, and overall neuroprotection. For the pancreas, we do have what I was talking about here. Mechanism's not super as important, but this right here, glucose-dependent insulin secretion, the glucose-dependent will help us decrease the risk of hypoglycemia. Most of that was seen only, hypoglycemia was seen only when associated with other anti-hyperglycemia medications. But in and of themselves, the GLP-1s, not huge hypoglycemia risk factor. Increases beta cell proliferation and survival. This is mostly the GIP, but overall GLPs can do, and then decreased beta cell apoptosis. For the pancreas, again, glucagon secretion is decreased, so decreased gluconeogenesis and glucogenolysis, and decreased overall glucose production. And then in the adipose tissue, the lipolysis is increased and the lipogenesis is decreased. Kidney benefits, because these are some of the indications for the GLP-1. Sorry, part of this is blocked off, but all in all, it's just talking about decreased inflammation and then decreased albuminuria. This was huge, about like 50% decreases in albuminuria with GLP-1 receptor agonists. And then this, yeah, I knew this was coming. Good picture on sort of the improved endothelial functions, increasing nitric oxide production, decreasing blood pressure, and overall anti-atherosclerotic, protection and cardiac protection. And then in the liver, some of what we've already said before. Of course, if we are packing less, free fatty acids into the liver, we're also protecting ourselves from hepatic steatosis and metabolic related steatotic liver disease. Moving on. All right, safety and tolerability. So again, I already talked about this excessive, no excess of hypoglycemia. Most of that was seen if they were coupled with other type 2 diabetes medications. This pancreatitis and pancreatic cancer is one big one. A lot of people, we ask, like, do you have a history of pancreatitis? A lot of this was mostly chalked up to maybe it was related to the effect on cholecystitis that was seen, and all in all gallbladder issues. However, pancreatitis and pancreatic cancer in and of themselves was not seen compared to placebo and in the cardiovascular outcome trials, meta-analyses. Predominant adverse effect here is nausea, vomiting, diarrhea, constipation. I'm sure we've all heard about that. But if titrated appropriately, this can be mitigated. And if you give, supportive medications and things like that, this overall can go away in time. Of course, there's gonna be an aspect of finding a medication that works best for your patient. Not all meds, you'll see some patients say, I could not tolerate the semaglutide, but then as soon as I got on tirzepatide, I was okay. There's gonna be a period of time where you're trying to get the patients on the appropriate medication. It's the long game that we're doing here, so that's okay. But just stay on top of it and we'll get the outcomes that we're hoping for. Increased, this is the GI and gallbladder events, not seen very often, but this was bigger more so than any sort of significant pancreatic effect. And that might have been secondary to the gallbladder effects. And then all in all, just contraindicated in personal or family history of medullary thyroid carcinoma or MEN2. Efficacy and outcomes, bear with me, a lot of these showed essentially, so there's a 3-point MACE outcome in the cardiovascular outcome trials, and MACE is major adverse cardiac events, and the 3 points include cardiovascular death, non-fatal MI, and non-fatal stroke, right? And a lot of these showed benefit in all of that. So you'll see a lot of repetition, but all in all, this is showing you that this is beneficial. We want to stop the strokes and the heart attacks and the cardiac death, right? So here for the glycemic aspect, reducing hemoglobin A1C by 0.5 to 1.1% in cardiovascular outcome trials, and then the lowering of blood pressure by 1.4 to 5.4 millimeters of mercury overall. Those are the two things I want to focus on. Some of this is just a repeat. The weight loss efficacy by agent, here liraglutide showed about 5.8. I organized it in, increasing percentage of weight loss. 5.8% at 26 weeks. Semaglutide, 2.4 milligrams, 13% weight loss at 68 weeks. Tirzepatide, which is our first GIP GLP-1. This is the most efficacious at this point, showing up to 17.8% and up to 21% in some of the articles that I read at 72 weeks. And then semaglutide, which is the most effective among single agent GLP-1 receptor agonists, because this one has the GIP, is what was found. And then these, just the rankings, all in all, tirzepatide and semaglutide were top, but then tirzepatide with that added GIP effect, which essentially protects the islet cells and increases survival, added just that extra efficacious factor to tirzepatide. Cardiovascular outcomes, the major landmark trials. I know there's so many trials out there about this. We need a little bit more done on long-term effect, but as it pertains to the overall benefits, the LEADER trial was about liraglutide, included this many patients with type 2 diabetes and high cardiovascular risk. Again, that 3-point MACE reduction of cardiovascular death, non-fatal MI, and non-fatal stroke, was met with a hazard ratio of 0.87, less than 1, and driven largely by the lower cardiovascular mortality. The SUSTAIN-6 was on semaglutide, this many patients, again, MACE reduction largely driven by the stroke reduction with a hazard ratio of 0.74. REWIND was for dulaglutide, the same here, MACE reduction, a lot of, repeated and emphasized support for cardiovascular success. And then more landmark trials, the SOUL, so this was for oral semaglutide, this many patients, 14% reduction in cardiovascular events overall, establishing POS. This is essentially the trial that established the oral semaglutide's cardiovascular benefit. Pioneer 6 showed semaglutide non-inferior but not superior to placebo, but this was semaglutide oral, again, but in conjunction with our regular management of cardiovascular events. But most of the other injectable forms were non-inferior and superior, superiority that was proved. For the SUMMIT trial, tirzepatide again, and this is where we, sort of added that HFpEF and obesity component for toward the cardiovascular health. All right, and then benefits beyond, so I know maybe some of you who are aware of this, there is the SELECT trial that I didn't mention on the last slide, because the big thing about this trial was these people included in this trial did not have diabetes. So this was trying to show okay, is all the benefit we're seeing because these patients had diabetes, essentially we tackle that and we tackle the cardiovascular risks. And this one was patients without diabetes, and we still showed reduction in the major adverse cardiac events. And so major point to take away here is cardiovascular benefit is still partly independent of glucose lowering and can still be beneficial even in patients who don't have type 2 diabetes. These overall, sorry, one second. Perfect. These overall meta-analyses, huge amount of patients, just looking overall at the 3-point MACE reduction again, still completely relevant, showing reductions in cardiovascular mortality, all-cause mortality, stroke, heart failure, hospitalization, and benefit is consistent with and without established cardiovascular disease. Larger meta-analysis, even more patients, still conclusive reductions in all-cause mortality, cardiovascular mortality, and MACE across the subgroups. The renal outcomes, so this is one of our indications for, and why I'm emphasizing this, I know this can be sort of redundant for you guys, but now I'm emphasizing sort of what indications we can start prescribing these patients for, because I know some of them want to lose weight. They're coming with GLP-1s because they want to lose weight, they want to lose weight, they want to lose weight. And ultimately, we want them to lose weight, right? Because losing weight ultimately helps with a lot of these cardiovascular disease issues in the long run, right? But how can we get them on these GLP-1s if they're not meeting all the criteria? So that's why I thought it was important to sort of talk about all the indications so that you guys can find one and hopefully get our patients on there. I know it's not that simple, insurance and all that, but this is step one. So the FLOW trial did show 20 to 25% reduction in major kidney disease events in type 2 diabetes with CKD, with meta-analyses showing 19% reduction in composite renal outcomes and 24% reduction in microalbuminuria and slower eGFR decline. Reduced albuminuria and slow eGFR decline ultimately delayed the kidney failure. Hepatic outcomes, so semaglutide, at this point, I believe semaglutide is the only medication that is FDA approved for hepatic steatosis. But this showed steatohepatitis resolution in 62.9% and improved fibrosis in 36.8% compared to placebo. Tirzepatide showed some liver fat reduction up to 47% with high resolution and fibrosis regression. And then resolution, and fibrosis regression. Hepatic effects were largely indirect, associated with weight loss, reduced lipotoxicity, and inflammation. All right, in combination with SGLT2 inhibitors, so I just put this here to show that although there is an additive and complementary benefit to doing GLP-1s and SGLT2 inhibitors together, regardless of using them together, there was still benefit shown in just the GLP-1 receptor agonists on their own. Further on indications, again, I like my charts. If my 3 beautiful charts are the only things you guys remember, I'm okay with that. This just essentially gets into the ones that are approved. As you can see, this one's not connected. I wanted to emphasize that. This is just upcoming sort of indications for GLP-1 agonists, which you can imagine there's so many. But currently, these are the indications that we can prescribe for our patients. Look into the details because some of them have like specifics that you need to meet. Like when it comes to here on semaglutide specifically, BMI of greater than 30 kilograms per meter cubed, squared, sorry. But if you do have a 27 BMI, but you have some of these, and it kind of speaks to what those comorbidities are. If you have some of these comorbidities, you can start treating at this point. Because I know a lot of us are like, if you're obese, we can treat. If you're obese, we can treat. You can also treat if you're overweight, but you have these cardiovascular risk factors. The chronic kidney disease, again, slows progression, slows persistent eGFR decline, or slows down or stops this, and then renal or cardiovascular death overall. Here's our 3-point MACE reduction, cardiovascular death, non-fatal MI, and non-fatal stroke, and then the heart failure benefits that we saw here. And again, the type 2 diabetes we know very well. So I thought this was a nice sort of summary slide for the indications associated with each medication. So semaglutide, Ozempic we know is for type 2 diabetes. Rybelsus was one of the oral forms, which I need to look into this, but one of my patients just told me because it's made by the same company as Ozempic, or Wegovy, that they're actually not making this anymore and trying to put all their patients who were on it on the Wegovy pill. But ultimately indicated for type 2 diabetes and MACE reduction and chronic kidney disease, as well as ESRD and ESKD, sorry, that's the new term. Does everyone know that, by the way? The new terminology for ESRD? Because a lot of patients don't really know what renal means, so they're promoting saying end-stage kidney disease instead of end-stage renal disease. So that's what that is, in case it's confusing. And then obesity. So semaglutide can be used down to adolescents who are greater than or equal to 12 years old. And then the big thing here is this one's the only one where MASH is listed as an FDA-approved indication. Tirzepatide, again, Mounjaro and Zepbound, depending on weight loss versus type 2 diabetes. Here we are. This one, again, only obstructive sleep apnea for this one, indicated for this one. And then dulaglutide, we have the MACE reduction. This one important because down to age 10 we can utilize. I know some people are wondering, hey, can we use these in kids? Nothing less than 10 that I saw as I was reading, but at least 10 and 12 years old, depending on the agent, we can utilize. And then liraglutide, Victoza, Saxenda, these indications down to adolescents as well. And then Foundeo, I know the commercial is really big right now on TV. This is another oral daily pill that people can take for obesity. And then you guys will have these slides, so you'll be able to look at that slide. If you're trying to remind yourselves, it'd be nice to get some charts in our clinic so that we can just do a quick look-see if we have a patient pertaining to one of these. Quick thing here, these are the routes of administration which we're aware of. We have oral, we have injectables, and these are our orals, plus or minus Rybelsus. And then right now, as of October 2025, 12 GLP-1 therapies are approved for type 2 diabetes or obesity, and there's over 40 in development currently at various stages. And that's it. So emerging indications. All right, so HFpEF, I know some use is already occurring, but there's even more emerging indications associated with weight, inflammation, and effect on hemodynamics. Type 2 diabetes prevention, right? A lot of these medications can be utilized for type 2 diabetes already diagnosed. However, upcoming will be things like prediabetes, which will be nice. It's just hard financially at this point. It's already hard for people who need to be on these medications financially to be on right now with the current indication. So you can imagine if we start adding prediabetes to that list. But still, nonetheless, upcoming, as well as for indications for peripheral arterial disease. Knee osteoarthritis, PCOS, metabolic liver disease, neurodegenerative diseases. This was one interesting one for me. Alzheimer's and Parkinson's, specifically for Alzheimer's or neurodegenerative issues, liraglutide, semaglutide, and dulaglutide. So far, the ones that essentially showed benefits so far in reducing the beta amyloid and the tau pathology. So that could be upcoming. It looks promising based on what I was reading, but we're just not quite there yet. And then next generation agents, I think a lot of us, and I know we recently had a talk on GLP-1s as well, but a lot of us have probably heard about this retatrutide, which is going to be a triple agent, essentially targeting GIP, GLP-1, and glucagon. And some other sort of dual agents coming up alongside, tirzepatide, which is already approved, which will have GLP-1 and glucagon or GLP-1 and amylin. There are also some other agents on the market that are showing efficacy of decreased weight reduction or decreased rate up to 20 to 25%. I think the highest, like I said, for tirzepatide, which is the most efficacious in weight loss, was 21%. So getting up there. And then also some small molecule GLP-1s are there that are hoping to mitigate convenience for patients, but still that GI tolerability remains a limitation. The major takeaways for this presentation, for me to you, is essentially we have found metabolic syndrome's perfect fitting dress to sort of help with the main aspects of metabolic syndrome, and that is GLP-1 receptor agonists. And I want us to try to correlate, work closely with our patients, work closely with our attendings to try to get our patients on these medications, because again, you guys know a lot of our population has these risk factors, meet the metabolic syndrome criteria, and could really benefit long-term. GLP-1 receptor agonists, essentially are reducing weight loss. The MACE 3-point mortality, 3-point outcome, mortality, renal decline, and hepatic steatosis and fibrosis, as well as OSA and other emerging things. And then indications are now expanding beyond obesity, cardiorenal, and all of that into things like neurodegenerative disorders. Okay. So now I have some questions for you guys. They're not super hard. I didn't want to, you guys are busy and doing a lot today, so. Get a microphone. Yeah, okay, let's do it. Yes. But I will ask for someone to read the question, and then, we can talk answers.
Oh, excellent. Thank you.
Thank you, Nadal.
61-year-old, excuse me, 61-year-old man with type 2 diabetes, A1C 7.5, obesity, BMI of 36, prior MI, CKD stage 3, taking metformin and Lipitor. Which evidence-based benefit of adding a GLP-1 receptor agonist is best supported by randomized clinical trials? Is it A, regression of coronary artery calcifications, B, reduction in major adverse cardiovascular events, C, reduction in ventricular arrhythmias, or D, elimination of the need for statin therapy? B. B. Everyone's saying B.
B as in boy?
Yes.
All right, good. I only harped on it through the entire presentation, so I was hoping you guys got that one right. All right, next question.
You would like someone to read it from the audience?
Yes, please.
Okay, let me find somebody. To read.
Which of the following medications has demonstrated the greatest average weight loss in clinical trials? A, liraglutide, B, semaglutide, C, tirzepatide, D, exenatide. C.
Very good. And last question.
Read. Will you read? Thank you.
Which of the following is currently an FDA-approved indication for a GLP-1 based therapy in the United States? A, prevention of progression from diabetes to type 2 diabetes. B, treatment of heart failure with preserved ejection fraction. C, treatment of metabolic dysfunction associated steatotic liver disease. And D, treatment of moderate to severe OSA in adults with obesity. C. Okay, I guess it's D.
Okay. All right, all for A? No. Anyone for B? Anyone for C? Okay. And then anyone for D? Oh, C and D. Anyone think it's a little bit of a trick question? How many? It's a trick question. Technically, I only highlighted one accidentally, but technically the C and D are follow-up question, what is an upcoming indication? Because I do have one here. Very good. All right, okay, so that's really it, and that's my, it's the ND, yes. But it was a trick question because only like one, the semaglutide was FDA approved for that reason, yeah. And then references, and that's it. Any questions?
All right. Thank you, Dr. Idowu.
Thank you.
If you're viewing online and have a question, please enter it into the chat and we'll ask that for you. But in the room, any questions or comments? Okay.
That was a great presentation, Cindy. What's one thing you would want most residents to take away after one thing from this presentation that we could use in our clinics and in our hospital as well?
Yeah, actually, I'm glad you asked that question because I meant to bring this up as well during the presentation. But and something I wanted to emphasize was in an earlier slide where I talked about they did the lifestyle modifications and wanted to see if we could have sustained remission of metabolic syndrome. And they said we can, but it'd be best with an agent, a GLP-1 agent assisting during the treatment period, right? But I was also thinking about the reverse because a lot of my GLP-1 receptor agonist articles that I was reading were all talking about coupling all of this with lifestyle modification. So the reverse is also important. So that's my biggest thing I wanted to, especially the residents, to walk away with, is if we're really trying to achieve this longevity for our patients and health of our patients overall, understanding these agents and knowing that sustained remission is only going to be possible not necessarily just by slapping a GLP-1 into a patient's medication list. And I urge you guys to clarify this to your patients as well, because they think, hey, I tried to lose weight, I haven't dropped anything, I've plateaued, or I've dropped a little, but I plateaued. A lot of patients forget that you have to still eat healthy. You have to still limit your caloric intake. Most people can probably half their meal portions and still get enough nutrition at this point, especially the way meal portions are here in the United States. So a lot of the times when I'm addressing this with my patients is, I'll start with, well, so far tell me what you've done to try to lose weight. Are they committed to the lifestyle changes that are gonna be important to sustain whatever these GLP-1s can do? And most of them are not doing our CDC recommended 150 minutes of exercise, cardiovascular exercise a week, eating healthy, doing a Mediterranean diet. And I know this is a long-winded answer, but this brings me to a family member who's also on a GLP-1, a close family member who was saying, hey, I'm taking this medication, we've ramped up the dose, I've just plateaued, but in the same breath of wind, they're saying, hey, man, like, I'm not hungry at all. Like, I've barely eaten today. Like, I still need to eat, right? So I'm like, okay, well, tell me what you've eaten today. They proceed to tell me what they've eaten, and I pull out my MyFitnessPal app, and I start putting in everything that they've eaten, and lo and behold, they thought they've just snacked all day and eaten maybe 500 calories or so because they're feeling that, slowed GI emptying from the GLP-1 effect. But if you think about what we eat here in the United States, most of it is not right and has very high levels of calories and nutrition or nutrients that are non-existent, right? So I put in those numbers and they saw that, lo and behold, the snacking still equated to about 1,600 calories, which is essentially the deficit that they were trying to stay under, right? So I emphasize to all my patients, you have to do the work, you have to exercise, you have to mind your diet. One of my patients says, I just half everything. Now I eat 1 pizza instead of 2. Now I eat, but you're still eating pizza, right? So you have to like really spell it out to them, and it's the long game, right? And then encourage them not to really meticulously calorie track, but just be aware of how many calories are in what they're eating. And lastly, I always tell them that if you go to like a Longhorn or something like that, and you get one meal, right? I say you get a steak, you get the side, and you get your sugary drink. You've met your calories probably for the entire day. And I also remind people who say, it's just one large Chick-fil-A fry that I ate alongside my sandwich. Chick-fil-A fries are 600 calories a large. A spicy deluxe is like 550, 540 calories. So just there with the fries and the spicy deluxe, you're at 1,000 calories. Let your patients be mindful. That was part of the ELM trial. Mindful of what they're eating, how many calories they're intaking, and that GLP-1s can drop your weight, but they won't sustain the loss of that weight or metabolic syndrome. So long-winded, but very important. Any other questions?
Any other questions or comments?
What a great presentation
Thank you.
and fabulous style presenting it. I do have one complaint, and it involves changing the name of end-stage renal disease to end-stage kidney disease because it happens to be more colloquial. We might do all our referrals to the brain doctor and all our referrals to the skin doctor and all our referrals to the nappy toe doctor. I don't know. This could open a Pandora's box that I think is not wise, and I won't be using it in my teaching.
I will let them know.
Thank you, Dr. Idowu. Great
You
presentation.
guys.